the almost like a mecca of airway surgery, is the head of the unit there in Cincinnati Children's Hospital. Over to you, Dr. Mike.
Thank you, and hi, Kaylin. Good to see you too. So I'm going to kick this off. I'll share my screen, and hopefully I will get this right with a bit of luck. And now let's see, that looks promising. So let's do that.
There we go.
And there we go. That looks decent.
Yep.
Okay, let's roll it. So I'm going to talk a little bit about laryngeal webs. And again, thank you very much for the invitation to come back to India virtually. And because I'm in America at the moment, I'm going to do the mandatory disclosure slide, which doesn't really relate a great deal to what we're talking about today. But I've worked with a lot of people, and I've got a balloon dilator I've designed. I've got a stent with my name on it, and there's things like that, which I don't think really matter too much. So let's give a very brief, simple overview of laryngeal webs. You can consider laryngeal webs as congenital or acquired, and repair may be open or endoscopic. So at its very base level, those are the fundamental themes. And really, for me, the key concept is, are the vocal cords scarred? And if you've got a congenital web that no one's done anything to, you're going to have mobile mucosa on the remaining vocal cord, and you've got the potential for an open repair to give you a better long-term vocal result. And I'll try and take you through that shortly. If you have a scarred web, someone's tried to divide it with a laser, for example, you will not be able to mobilize mucosa, and you're very likely going to have to place a keel to allow remucosalization of the raw surfaces. And whether you do that open or endoscopic, we'll sort of briefly touch on as well. And so I'm now going to show you a series of photos, and each of them is of a slightly worse congenital web. And really, webs are actually, in the majority of cases, a form of congenital laryngeal, partial laryngeal atresia rather than a true web. In other words, the bit that you see at the bottom is thin, but the closer you get anteriorly towards the thyroid cartilage or the cricoid cartilage, the thicker the web gets. And so often you have an associated subglottic stenosis with either a small cricoid or an abnormally shaped cricoid. And I have a fabulous bit of artwork that I will show you later on this that I drew myself. In other words, it's absolutely appalling. But even so, we will get to that in due time. And let's see, this is what I'm trying to talk about in terms of the thickness of the potential subglottic stenosis. So this is a xenogram. This is a 30-year-old X-ray. You don't do these anymore because it involves a lot of radiation. But what it's showing is that the web at the apex is thin, but at the base it's very thick. And the term that used to be used was a subglottic sail because it looks like the sail of a yacht. And that is not going to do well if it is tackled endoscopically, because you're only seeing the tip of the iceberg with the apex of the web. And with most of these webs, the symptoms primarily are of an abnormal cry at birth. If you've got a laryngeal web, you're not going to have normal cry. Now, interestingly, children hide airway obstruction extremely well when it's congenital, and whether this is a congenital subglottic stenosis or complete tracheal rings or a laryngeal web, by the time they're significantly symptomatic and you go and have a look, you tend to be surprised by just how bad it actually is. And if someone presents with a significantly compromised airway, when you actually have a look at it, you're going to be very disconcerted about just how small the airway may be. And so voice compromise tends to be the dominant presenting feature. If they've got an airway compromise, it's going to be a bad web. And so now we're getting into more and more severe webs. The one on the right is a complete blockage. And so there's no hole at all. And this is a child who was at birth, because no one knew this was coming. They couldn't intubate, and it ended up with the endotracheal tube in the esophagus. And he was able to stay alive, breathing through a tracheoesophageal fistula for 2 hours till they found someone who could place a tracheotomy. And he did eventually get his tracheotomy out, but it took some significant surgery to achieve it, and we'll talk a little bit about that later on as well. So some of the complete webs also may have a tracheoesophageal fistula. And so if you've got a child who presents to you not intubated, not trached, the first thing you always do, as with everything, take a history, do an examination. The history: is there a voice problem? Abnormal cry. Is there an airway problem? And the key examination is a transnasal flexible laryngoscopy awake. That is going to tell you about pathology, vocal cord level and up. And the vast majority of children born with stridor will have pathology seen on a transnasal flexible laryngoscopy: laryngomalacia, vocal cord paralysis, laryngeal web. If you know what you're getting into, you're in a safer position then moving forward, taking them to the operating room to do a diagnostic bronchoscopy. And then the other thing that is mandatory to do with a laryngeal web: test them for chromosome 22, Q11, used to be called DeGeorge or velocardiofacial syndrome. They're all on the same spectrum. Embarrassingly, I'm old enough that I believe I was the first one who actually noted the association, and I think I wrote the first paper on it, or something like that. And about 60% of children with a laryngeal web will have an abnormality of chromosome 22. Now, occasionally, and we just talked about this, you can get a complete glottic web with a tracheoesophageal fistula. I showed you that video a little bit earlier. And these children give you no warning. And if they are not stabilized with an esophageal intubation, they die. So you tend to only see the survivors by definition, and these are usually trached very soon after birth. These tracheoesophageal fistulas are extremely hard to find. Usually you're looking through the trach site and you can't find it, and you say, well, there isn't a fistula. Well, again, if they were surviving before the trach went in with an endotracheal tube in the esophagus, there's a fistula. And if you do dye testing, you use food dye, and if it comes out the trach tube, there's a fistula. Typically, the fistula is at the lower border of the cricoid, so they are incredibly hard to find looking through the trach site, because it's very hard to look up through the trach site. if you know what you're doing, you can find them looking down the esophagus, looking anteriorly at the bottom of the cricoid. These are difficult webs to repair. Do not rush a repair. I'm going to go into this in more detail when we talk about something called chaos. So we'll get to that soon. And so, should you do an endoscopic division? For a congenital web, and this is an example of a congenital web, an endoscopic division only works well for the very rare through gossamer thin web. And this one, you can almost see through it. And so most webs are a form of partial laryngeal atresia. Some webs, very rarely, are extremely thin. And those webs, almost anything you do works. I mean, if you blindly intubate them with too big a tube and you pop the web, it's probably going to work. You can use scissors, you can use a sickle knife. If you want to, you can use a laser, though it's a little bit of overkill. Pretty much anything you do for these works extremely well. Now, I'm going to talk about doing an open repair for a congenital web that no one has interfered with. And so the key here is that the mucosa is mobile. So you do a laryngofissure, and this is artwork trying to depict that. And really the key artwork is this. And so you've done the complete laryngofissure. This is the cut edge of the web here. And if you use pexing stitches to grab the mucosal edge and you put them through the thyroid alar, I tend to use a 6.0 double-armed PDS on BV1 needles. You can pull this mucosa all the way up to the thyroid cartilage on both sides because it's very mobile. And then you close the larynx and you end up with something that looks like that. And here's an example. This is a girl who's 3 weeks old. On the left, this is her at 3 weeks. On the right, this is her at 9 weeks after we repaired her. She's got a pretty significant web. She has never had a tracheotomy. She has quite a lot of stridor when she's upset. And we did a complete laryngofissure, pulled up the cut edge of her mucosa up to the thyroid alar on both sides, closed the larynx, no keel, single-staged, extubated 2 days later. Now, interestingly, this girl, 15 years later, 16 years later, popped by the hospital because she's a ballerina and she was looking at potential places to go to college. And just on a whim, she and her mother came into the hospital on a Saturday to have a look around, and I happened to be on call. And they were very kind to give me a photo of her. And as you can see, she's a normal kid. The thing that was quite interesting is that she thinks she's got a normal voice. I don't think she's got a normal voice. It's really subtle, but it isn't quite normal. She doesn't know that. And of course, this is a Saturday morning when I happened to be on call. I couldn't exactly shove a telescope down her nose and have a look or do a strobe, so I've got nothing to back that up. But I can assure you that she thinks her voice is normal. And so why an open web repair? This is because the mucosa can be mobilized and attached to the thyroid cartilage to help recreate an anterior commissure. So you've got the potential for a mucosal wave. And in theory, you have the greater potential for a long-term better vocal outcome. If you've got scarred vocal cords such as you get after a keel, scar tissue doesn't vibrate as well. It's very simple. And so open web repairs The other thing that you have to bear in mind is they can be associated with subglottic stenosis. Here's a nice example here. Significant subglottic stenosis. And this is where you may need to use an anterior graft through the cricoid. Sometimes you can actually put a posterior graft in. This is pre and post reconstruction, these two photos on the same child. And that way you can spread the posterior cricoid to help hold apart the top of the web at the anterior cricoid. And this is the artwork I told you about. Isn't this fabulous? I did this years ago because someone was asking me about a web. And what I'm trying to illustrate, this is thyroid cartilage in a normal airway, cricoid cartilage, complete tracheal rings. But if you've got DeGeorge or velocardiofacial syndrome, the reason the web is thick and you've got a subglottic stenosis is the cricoid is abnormal and it hooks down into the airway. So this is, I term it a cricoid hook. Maybe one day I should get off my ass and publish that. But anyway, whatever. And the web blends into this. And so trying to laser this is doomed to failure. And what you can actually do, apart from grafting the cricoid, is you can actually do a submucosal resection of part of the hook of the cricoid and open up that airway quite significantly. And if you do that, you don't need as big a graft. And so you can actually just cut through there and remove some of this here. And it actually works quite well. A little bit fiddly. So let's move on to open web repair. I think we've got a few more minutes. So when to do it. We talked about why to do it. If you've got obstructive symptoms as a neonate, you can reconstruct as a neonate. As you saw, we did quite an impressive one on a 3-week-old with a good result. If they've already got a trach, wait. If they don't have a trach, but they don't have any obstruction, wait, because it's just easier when they're bigger. Typically, I'd like to reconstruct when they're between 2 and 5 years old to assist with their voice before their school age. Now, if you've got scarring, that's when you need to think about an open keel. So here's a completely scarred off larynx. You're going to have to do a complete laryngeal fissure. You're probably going to have to graft the front and the back. You're likely to need either a long-term stent, and then you come back and fix the resultant anterior re-webbing, because it'll always do it to a degree, with an endoscopic keel, or you can put a keel in at the time, and you can do that actually running down the side of a stent. And so let's talk a little bit about chaos. We alluded to this before. So chaos stands for congenital high airway obstructive syndrome. And this is basically when you've got a complete laryngeal atresia without a tracheoesophageal fistula. Now, this is usually diagnosed prenatally if you've had a prenatal ultrasound. Now, in America, this is almost ubiquitous, but not in all of the world. Typically, you see hydrops, you see everted diaphragms, a very big trachea, and they tend to have prune belly syndrome. And these kids need an exit when they're born. They just need to be trached as soon as they come out. Frankly, you can do a vaginal delivery if you want, but you have to put a trach in fast. It's a very big trachea, so it's really easy to put a trach in. A lot of these mothers have very significant polyhydramnios, and so they're often delivered early. There's often significant fetal hydrops. This is an example of a boy with chaos. I eventually got him when he had had, I think, 15 surgeries, and that was after 15 surgeries. And I got his trach out, but it took a little bit of work. Now, these are difficult repairs. Children born without a laryngeal lumen don't like to have a laryngeal lumen, and they tend to rescar. The cricoid tends to be small, it tends to be solid. I strongly advise you put a trach in when they're born, you repair them when they're at least 4 years old. I tend to do a cricotracheal resection with a complete laryngeal fissure. They might need a posterior graft. They do need a very long-term stent or T-tube. I think Kaylin's got some experience with this as well. And you want a stent for a really long time, because if you take the stent out early, they just close off, and then they're much harder to resurrect. Now, let's briefly talk about endoscopic web management. So this is ideal for minor congenital webs or for acquired webs. And this does not necessarily require a tracheotomy or intubation. And so this is a girl who's had 60 laser procedures. She's got anterior webbing, just using a sickle knife to divide that. A tool is a tool. You can use a sickle knife, you can use scissors, you can use a laser, whatever floats your boat. And I actually quite like to place a small silastic keel using the smallest bit of silastic that I can steal off my otologist colleagues. Nowadays, I'm actually using a little bit of angiocath to reinforce that, and the angiocath bit threads in between there. And so I put a Keith needle in below the web, out through the mouth, thread on a piece of silastic, put a hollow angiocath above the web, thread the needle up the angiocath, put it in place, tie it down, and leave it for 2 or 3 weeks. So here's threading the needle back through. Extremely heavily edited video, because this is really fiddly. I mean, this looks like we've done it really fast, but it's very, very irritating doing this. You've just got to keep, drives you absolutely crazy as you do this. This is on the right with it in place. 2 weeks later when we were about to remove it. And this is after the removal, 6 weeks later. And again, her voice markedly better. Interestingly, she said she didn't have an exercise problem, and she came back and said, I'm breathing so much better. She didn't realize she had an exercise restriction. So I'm going to wind it up here. So most congenital laryngeal webs are not thin. Most congenital laryngeal webs are associated with a chromosome 22 anomaly. Therefore, test for it. Even severe congenital laryngeal webs may have enough mucosal mobilization to help recreate an anterior commissure if you do an open repair. Scarred webs are better managed with a keel, be it endoscopic or open. I'm going to leave you with the Airway card that our hospital developed. Most of you already have this. If you don't, it's free. Just download it, whether it's an Android or an Apple. It's called Mobile Airway Card, and it's useful. I'm going to stop sharing my screen at this point. Okay, that seems to have worked. Hi, Kaylin.
Thank you, Professor Mike. I request you to stick around because we are going to take questions in the panel right after Dr. Anju's talk.